Hi, my name is Dana Valenta, and this is my clinical conference patient presentation. JS is a 62-year-old Caucasian male presenting to the clinic for a follow-up blood pressure check. He first presented to the clinic 2 weeks ago after his dentist would not remove his remaining teeth prior to denture fitting because his blood pressure is too high. 2 weeks ago, he started on lisinopril 10 milligrams PO daily. He says that he has been taking the lisinopril every day and has not missed any doses, and he does not have a previous diagnosis of hypertension. Illnesses, just the hypertension diagnosed in June 2014. Denies hospitalizations. Family history, his father died at age 68 from an MI, and his mother is alive and healthy at age 75. He denies additional family history, stating everybody else is healthy. Health habits, he smokes tobacco, 10 cigarettes per day for the last 2 weeks, but has been a half pack to 1 pack per day smoker for the last 25 years. He drinks beer, usually 2 drinks per day, states his last drink was 1 week ago. He denies additional illicit drug use. He has no known drug allergies, and his medications, other than his lisinopril, he denies. He denies any over-the-counter use or use of supplements. Exercise, he denies dedicated exercise other than the exercise he gets from being at work. In nutrition, he can eat only soft foods because of poor dentition. He eats a lot of processed foods such as boxed meals, frozen foods, and canned soups. Review of systems, he denies dizziness, weakness, anxiety, significant stress or pain, denies headache, epistaxis, vision changes, blurring or double vision, denies chest pain, jaw pain, palpitations, shortness of breath, wheezing, difficulties breathing. He says that he has an occasional cough in the morning with small amounts of dark yellow sputum. He denies edema or leg cramps. Nursing database, he understands that his actions affect his health and he is willing to take steps to change his lifestyle and to take blood pressure lowering medication consistently. He's insured by Medicaid and has adequate funds to pay for his medical visit and prescription drugs, but has minimal funds to purchase fresh fruits and vegetables or purchase a blood pressure cuff. Objective, he's a lean, unkempt male who's resistant to receiving health care. He's not interested in healthcare promotion activities, and he does not appear to be anxious or in any acute distress or pain. Vital signs, temp 97.2, pulse 87, blood pressure 160/100, respiratory rate 16, SpO2 92 on room air. He has no orbital edema or puffiness. His fundus is grossly intact without hemorrhages. Cardiac S1 and S2 are present, no S3 or S4, no murmurs, rubs, clicks, bruise, or thrills. Rate is regular. PMI is at the 5th intercostal space, midclavicular line. Respiratory rate is regular, unlabored. And his lungs are clear but diminished in all fields. No wheezes, crackles, or rhonchi. No renal artery or abdominal aorta brewery. Pedal pulses are +2 bilaterally with no edema. Assessment statement, he has a lot of factors that could be contributing to his elevated blood pressure, including a high salt diet, lack of exercise, tobacco smoking, and alcohol intake. He does not appear to have any additional disease processes that could be causing his elevated blood pressure. Problem list, his hypertension, tobacco use disorder, unspecified disorder of the teeth and supporting structures. So the plan for his hypertension is to increase his lisinopril to 20 milligrams PO daily. We did a lot of education with him as well. We discussed possible side effects of the lisinopril with him, such as the development of a cough, discussed not adding extra salt, and to look at food labels to reduce his sodium intake, encouraged him to hydrate with plain water, not juices or soda, encouraged him to keep a log of his blood pressures by buying a cup or going to City Market to take his blood pressure, and instructed him to follow up in 1 week to assess his blood pressure control. For his tobacco, we continued to encourage him to reduce the number of cigarettes that he smokes. And for his teeth, we recommended that he continue to follow up with the dentist. My evidence-based article, I reviewed the 2014 evidence-based guideline for the management of high blood pressure in adults. This article is a level 1A level of evidence because the authors only reviewed randomized controlled trials. The article gives 9 evidence-based recommendations on hypertension management. In the case of JS, there are 3 recommendations by the panel that apply to his case. Recommendation number 1, in the general population of 60 years and older, start therapy to lower blood pressure at a blood pressure of 150/90 or greater, and to treat to a goal of less than 150 or 90. Recommendation 6, in the general non-black population, initial treatment should include a thiazide diuretic, calcium channel blocker, ACE inhibitor, or ARB. And recommendation number 9, the main objective of hypertension treatment is to attain and maintain the goal BP. If the goal BP is not reached, increase the dose of the initial drug or add a second drug from a different class. So after reviewing this article in the case of JS, he was initially started on lisinopril 10 milligrams PO daily. This medication is an ACE inhibitor, therefore it is an appropriate medication to start with. He's now seen minimal blood pressure improvement, so we increased his dose to 20 milligrams PO daily, which is also appropriate since the maximum dose of lisinopril for the treatment of hypertension is 40 milligrams a day per Lexicomp. And this patient's dose of lisinopril can be increased all the way up to 40 milligrams per day before needing to consider adding another medication from a different class. This article is practice changing for the management of every patient with hypertension, and it should be used as a guide for every patient with hypertension. It is the most current evidence-based guideline for the management of high blood pressure in adults. My self-reflection on strengths and weaknesses. One of my weaknesses is streamlining my patient history taking. However, I think it is getting better the more I do it. I think I'm getting better at drilling down to the precise information that I need to take an adequate history about the chief complaint, and I found it helpful to use a template. And then completing a thorough assessment. I always feel like I've assessed everything that I needed to, and then when I start talking to my preceptor who asks, what about this or what about that, I realize that I've left some things out. Some of my strengths include talking to patients. I feel like I'm really good at asking questions in a non-judgmental, non-biased way, which is so important to the interview process and to establish a rapport and trust with the patient. I feel really good about knowing where to document the subjective and objective information as well. This patient was challenging to me because of his lack of health promotion activities. They initially led me to think that he didn't care about his health, although after talking to him, I think that he really did care and he was actively trying to improve his life by eating better and reducing his tobacco and alcohol intake. Since he's resistant to healthcare, I think in the future it would be a good idea to complete education a little at a time so he doesn't feel overwhelmed about what he all needs to do. And for myself, I need to remember that baby steps in the area of behavior change are not really baby steps at all. They're huge and they're very difficult for the patient to accomplish. Thank you for such a great semester, and I look forward to fall.